drastically decreased. The second picture showing the reduced in the void areas and capillary dropout areas and increased capillary perfusion. The third picture showing that how there was neovascularization and cotton wool spots can masquerade as a mild complaint but carries the potential for severe loss. In our story, the technology became our eyes. Thank you. We have already performed for 4 patients. We have done OPTA properly. 2 of our patients with OCT findings, and because nothing was that much in OCT findings, we lost their follow-up also. But in some patients where OCT was also normal, but OCT findings and what we were seeing clinically in the fundus, then we performed OPTA.
What was the treatment protocol?
Ma'am, for every patient, cycling in one patient with that neovascularization around the disc, we have given subcutaneous steroid injections also. Like one time we have given him, one time he has taken some other pace, and then also 3 injections we gave, and his neovascularization has reduced drastically according to that.
Subcutaneous injection?
Ma'am, because of neovascularization and edema, and
which drug you have given?
Sorry.
Which drug you have given?
Ma'am, we have given.
Ma'am,
we have given one, and one the patient has taken somewhere else. So he was not very sure, but this was
so at least we need minimum 3 PSTs, no? What is the presenting features?
The presenting features, everyone for 1 to 3 months they have suffered from fever and has taken their treatment from some physician or somewhere else and has shown to local eye pains.
Time of presentation fever was not there.
No,
Only
no patient at the time of presentation, and no patient was present.
duration of fever that the patients present.
Ma'am, who were well educated, they had presented within 2 to 3 weeks. But some patient came after 3 to 4 months and 5 months also. We have seen some people.
So did this long interval pertain to post-fever retinitis? Because for post-fever retinitis usually we take the duration of within 4 weeks.
Yes, ma'am. Ma'am, they are starting, diminution of vision started, but they thought that it is because of some other thing, so they ignored the thing. We have also performed all the investigation to rule out any other causes. Nothing was positive. So because of this clinical investigation and their history, we came up to this conclusion.
We have spent 10 plus years of training in the science of it. But have we ever dwelled that there has been absolutely no formal training in the business of our practice? And then, as soon as I finished our education, there are big questions. Where do we fit in ourselves? Do we go into a solo practice mode or an institution-based mode? Would we go into group practice? Do we go into corporate model? And we have all the questions, but there's not a single person there to guide us onto the right track. So let's start trying to understand the business of it in a minuscule way than in 10 minutes which I have. What is this art of business? At its very core, it is what is called as transactional. Like if you give something, it gives it back to you. So let's deliver the best. I'm sure we would reap the best, but then we have to define the level of involvement. Now, whole range of women ophthalmologists are there, and many of them in their early years have a family and a child or other issues to contend with. Now you have to be not doing just one role. You may be the doctor, you may be the center manager, you may find that maybe you have somebody to assist in the theatre, but you are a public relations officer. Everything you are doing, and you may have a small team also which should have to play multiple roles. Or else you join somebody into a basic module. You need to do very smart purchases. Like you have to really negotiate hard. You have to really inquire which is the best instrument which you can get, what are the long-term service contracts, and would this machine last at least for the first 10 years. You can't be making purchases and losses in the first 10 years of your evolving practice. 25-30 patients, you wonder why not I look at expansion, other ways of revenue earning. So
Okay, so I'm very happy So now I understand you are an excellent surgeon. You have done very good job in the tertiary hospitals. The thing is that the surgical part you have shown to us, and you have not shown about the posterior segment of fundus photograph nativity, and also the difficult technique that is iris management you have not shown to us. Only nativity is required. And you have not mentioned here, though it is a trauma case, you should mention the duration of the trauma.
Duration,
each cases and average duration
Yes, sir.
patient present to you.
Okay, sir. Thank you
You
for
not
that.
mention this.
For the last, the last patient, the 360 under dislocation into the AC, that was Bhubaneswar patient. Patient was that means with the stone, that is Gujar. But after 20-25 days, he came to with the PL plus PL inadequate 40-45 IOP. So we just did the lens extraction. Even after that, patient was the last follow because from the lowest strata. Almost all are that means after 1 to 1.5 years after the trauma. So that took some time.
No RT.
No. Only one patient that was having old hiatus emergency and macular thinning. The vision came well.
Glaucomatoscopy, the long-standing cases, trauma cases, glaucomatoscopy.
Glaucoma only I told na 2 patients has glaucoma and
the number is too less to give an opinion. It's done more, we have tried. And besides that, I think we have given the result, but 1 year assessment, after 1 year you have shown the 6.9 vision, in which he did not respond, came for checkup. Got a report.
yes. So the last presentation after 1 year, that means that vision is maintaining, I want to say. Yes, she came. We did the second trial after 2 months, then she was coming regularly.
I think I hope we will get an opinion. Okay. Thank you.
So, respected judges and all the delegates, my topic is prognosticating visual acuity in ophthalmic trauma at fast follow-up by artificial neural network. This is probably the first artificial intelligence-based study we are doing in Orissa, India. So, need financial interest. All of us know that ophthalmic trauma is avoidable cause of blindness. Till now, the ocular trauma score by Dr. Ferencz et al. That stands tall to prognosticate the visual acuity. However, it has limitations like it depends on a narrow set of variables and there is a need for more dynamic, comprehensive prognostic model that can incorporate multiple variables. So, ANN networks have been already studied in diabetic retinopathy, glaucoma and ARMD. In this study, we wanted to include the patients from IGATE's registry via artificial neural network and to prognosticate BCVR fast follow-up. These are the retrospective to Tirlosi Netralaya Sambalpur are included. A total of 238 patients included out of some 500 odd patients which qualified for the follow-up criteria. No specific exclusion criteria was applied. So, coming to the methodology, BCVA at fast follow-up was recorded in the IGATE study. Registry, a batch size of 16 and epoch of 150 and accuracy F1 score and receiver operating characteristic area under curve was calculated, training history was applied and this is in a nutshell the final model configuration of 128, 64, 32 and 16. It provided the best balance between model complexity and clinical prediction accuracy. So this was excellent, area under curve was 0.91, high sensitivity of 0.8 and specificity of 0.9 was there. F1 score at 0.87 and area under curve 0.91, making it strong predictive performance. So the next steps are for benchmarking, sequential prediction and external validation are needed. What is the utility in clinical practice? In the absence of all subspecialty department in resource scarce situations, include benchmarking against other machine learning algorithms. Thank you.
Model architecture.
What are the prediction?
So prediction was, this is again, I must say that statistical, what the statistical analysis told that 0.81 and 0.85 score true positive and true negative. These are very, very favorable in the prediction of the visual acuity less 6/36 or less. That means
Do you think that other factor that will modify your prediction?
So the management data. So we have a anonymized IGATE's entry that International Globe and Adnexal Trauma Study entry. So there how we have entered the data and whether the patients have come for follow-up or not. That is the biggest challenge because out of some 500 odd patients, only 238 patients we got. So there is a big dropout. If those patients, how they are affecting the outcome, that is also going to see.
Okay.
Presentation is a vigorous exercise in the Okay, in the office database, because it is a retrospective study.
Yes, sir.
So how will they get the message to the governments, and how that will be helpful to the other community if you
Yes.
think from your.
Yes, nice question, sir. So I'm sitting in somewhere say interior. One patient is coming. All the trauma cases we see, they come with the attendants, and mostly the violent situation is there in the emergency room. With all these presentations, if we have backhand that we know with certainty that this patient is going to get this much vision, we can tell with certainty to the patient. Maybe sometime in future, obviously, that with this thing you will definitely get this much vision. At least 6/36 is more or less with the protocol that we follow in our system, with the management that we do, with the protocol, with the follow, you will get this much vision. He will say, okay, I am happy, I will get better than 6/36. I am not happy, I want to come to a medical college or tertiary center and to go out of Orissa. At least we can tell that. That is one thing from the community or society thing. Our
This to the patient during for any treatment and the surgical manipulation, whatever may be.
Yeah.
So these are the things.
Yes, sir.
So there is no surety dot mark that you will get vision after operation, like this is not sure. This
So
from your variability.
the better than 6/36. That certainty only we are going to study in this. I cannot tell that you will get 6/6 or no PL. Maybe sometime in future somebody will be standing here and telling with the help of ANN and artificial intelligence. But as of now, as per my experience and this ANN application, I will tell that you will get with this much certainty, 90% certainty, you will get better than 6/36 or less than.
So final presentation give the
different decline, and all these findings were correlated with visual acuity improvement. Now, in outcome, after 6 months, visual, there was improvement in about 40% and no improvement in 46.7%, and fellow eye involvement was there in 3.3%. So in discussion, risk factors like diabetes, systemic hypertension were most common, and small optic disc was also a significant factor. And the findings were consistent with literature. OCT objectively demonstrated abnormal changes rather than visual function. And in limitations, it was a small sample and short 6-month follow-up with delayed presentations. In conclusion, NAION is the most common form of ischemic optic neuropathy in this cohort. Diabetes, hypertension, and disc arthritis are the key associations. Visual acuity, highly variable presentation, 53% showed significant improvement in 6 months. OCT monitoring of RNFL was.
Nowadays, it is responsible for around 30% or 35% of the NAION in young particularly. It is also seen in the NAION in elderly. But that is the most important risk factor which you have not seen. Serum homocysteine is the single most important risk factor. If the patient is also not diabetic, not hypertensive, not any other risk factors, raised serum homocysteine levels can cause NAION, and that is more commonly seen in the young patients, mostly nowadays. Next question is like, what are the clinical findings based on which you have diagnosed NAION? Pain?
Not as much as AION, but
What other things?
increased ESR and CNP values.
That is not clinical. I have asked about the clinical presentation. Based on the symptoms and
We
signs.
don't feel effects of that.
What else? In the fellow eye, that is the most important aging point in diagnosing NAION. Okay.
Difference in diagnosis. What are the difference in diagnosis?
Varieties also.
What type of reduced visual acuity? Reduced visual acuity means what type? Was it sudden, right? Or chronic progressive?
Sectoral NAION. Okay, go ahead.
Serum homocysteine. Why I am saying? Because NAION can be seen in patients not just elderly like beyond 50, but you can find the patients with NAION with a very classic longitudinal field defect, and then they are like in the range of that we call it as NAION in young. So never miss this particular investigation to order. And another entity is a disc drusen. That also is one of the second most common risk factor for patient to get that NAION. We call it as a mechanical NAION because the drusen is sitting in the disc head, right? So that is creating the compartment syndrome. And then as she has asked, like sudden onset vision, altitudinal field defect. If it is a repeat attack, then that becomes total field defect. So these are the things which I think we all should be aware about NAION. Thank you.
Good morning everyone. My topic is on alcoholic liver disease, the retinal nerve fiber layer. Alcoholic liver disease is a spectrum complex starting from steatitis to hepatitis to cirrhosis, and one is a major cause of chronic liver disease worldwide with 3.3 million deaths. With the change in the societal pattern of alcohol, with the involvement of younger age group, a higher consumption and pattern like binge drinking, we are heading towards an impending ALD epidemic. Various studies have shown that the oxidative stress caused by alcohol not only affects the liver, but also affects the brain by causing a neuroinflammation, breakdown of blood-brain barrier, degeneration of the glial cell and decreased blood volume. As eye and brain, they share a common intrinsic connection. The changes in the brain can manifest in the retina, which can be quantified by doing an OCT. So the objective of the study was to compare peripapillary RNFL in alcoholic liver disease patients as compared to normal control, and to study the impact of alcohol on the age-related decline in the RNFL thickness. It was a prospective case control study where we took 100 cases and 100 control. The cases were referred alcoholic liver disease patients greater than 18 years of age, and the control were healthy individuals with no history of addiction, age matched and with a BCVA of 6/9 or better.
यूनिक कलर गरम
Look at the outcomes, right? Because they are neither symptomatic as far as eye is concerned, and then we are just looking at what's happening with the RNFL. So I think I have a suggestion, like it would be great to look at MGCL, which is very important. Even in all the tests which you have done, you have that data with you, right? So you can a kind of the liver cancer or kidney cancer, and you keep on doing checking the how's the RNFL. So I think that relation has to be matched. If you are particularly looking at neurodegeneration, and the purpose is to anticipate those patients who has a cirrhosis, at what stage or what grade of cirrhosis probably we should suggest to go for eye screening, and that has a detrimental effect in terms of the eye manifestations. So I think structural function correlation is very important. It would have been great if you would have done the HDL, and then that would help also to rule out other causes. Now what she has said, like it could be a nutritional. So everything is mixed by us, right? So it's very difficult to take. I would personally take it with pinch of salt, because RNFL, you can see any disease process, irrespective of eye or beyond the eye, you would find those could be an age-related changes as well.
Today now let's see the nerve stories, clinical clues taken from 25 cases of ocular motility nerve palsies. Ocular motility nerve palsy are common cause of diplopia and ocular misalignment. They may arise from microvascular, traumatic, compressive or inflammatory causes. Careful clinical evaluation provides critical clues to localize the issue and infer the etiology. The aim and objectives of the study are to study the clinical profile of patients with oculomotor nerve palsy, to identify the patterns and localizing signs that help in the diagnosis, to correlate the clinical findings with the etiology. So the global prevalence of oculomotor palsies are like 40 to 70 cases per 1 lakh population, and among the etiology, if we see from the population-based studies taken from Europe and Asia, that 6th nerve palsy is the most common, followed by 3rd nerve and 4th nerve, and a microvascular ischemia remains the leading cause, followed by trauma, followed by traumatic, compressive or aneurysmal, followed by inflammatory idiopathic causes. The mean age was found to be 45 to 60 years. So our study included 25 participants from the Department of Ophthalmology, Vimsar, Kurla. It was a cross-sectional study taken from December 2024 to September 2025. And the results were as follows. Out of the 25 patients, the 14 patients were found to be male and 11 found to be female, and the mean age, average age was 44.7 years. The maximum patients were from the 21 to 30 years age group. Unilateral palsy was more common, followed by bilateral palsy, and seeing the nerve distribution combined third, then the CVA, followed by diabetes, myasthenia gravis, and tubercular meningitis, each 8.3%, and then it was followed by some cases of idiopathic hyperthyroidism and radiation. So in our series of 25 cases, we found out that 6th nerve palsy was the most common, which supported the literature findings, and most of the microvascular palsies in older adults were associated with diabetes and hypertension, while traumatic and post-infectious palsies were more common in younger individuals. Pain and pupil involvement served as an important differentiating clinical
examination
and languages and like
you will not do the Herzberg test, you will not do the cover test, or if cover test is not possible, then you can do the modified test. Okay, then on worsens. Then what will you do? Next, what will you check for?
Ma'am, we'll see whether the patient is having more deviation on tilting the head towards the same side.
We look for the reductions. Then, in case you are suspecting any 4th nerve palsy, what test you will do?
Ma'am, we'll see whether the patient is having any chronic illness or not, like taking
On examination, I am asking. You have to check for the pupil. It is very important to check the chorea or RPD that you have to see. Okay. Next is the fundus examination. So you have to go stepwise manner. Then only you can find the proper etiology of the cranial nerve palsy.
Studies. Also, or if the patient is having the restricted ocular movement along with pain, and there was also some history of nausea and vomiting. So we did one like MRI, and we got to know that it is a cavernous hemangioma that is causing the symptom. So by the symptoms, like we do not restrict ourselves to only to the clinical examination. Some neuroimaging is also essential for to infer the etiology.
We need to do neuroimaging in all cases.
Mostly the like older patients, those having any uncontrolled diabetes or hypertension, we can have a careful follow. But those who are having a progressive ophthalmoplegia or with pain or with diplopia or without any history of trauma.
Diplopia is not an indication for doing neuroimaging.
Young patients,
it is not resolving. Then we do
a neuroimaging.
So it's not the young patients or the diplopia is there. Any acquired case of strabismus can have diplopia. Okay.
The further bilateral fat vessel nervous. Not important. Bilateral fat vessel.
Diabetes can be the cause, and diabetes, ocular trauma, and any space occupying lesion.
Overall, and the pre-op Nelson grade was grade 2 and post-op Nelson grade was grade 0. Comparing AMG group versus CAG group, there was no significant differences between both the groups, but pre-op and post-op scenarios were significantly different. So this shows a slide, the pre-op photograph and the pre-op cytological slide and the post-op. So the mean goblet cell density pre-operatively was 13, which increased to 33, and the Nelson grade was 2, which reduced to 1. This is another case in which we did an amniotic membrane graft, and we can visibly see the difference. So, study participants were residents of urban areas, and the rest 65% were residents of rural areas. The reason behind this predilection is high number of rural people working outdoor jobs, for example, longer durations like farming, security personnel. Then comparing occupational outdoor exposure distribution, the duration of occupational exposure was graded according to the number of hours spent outdoors. The drop in the participants with exposure more than 4 hours was found to have more hours of nocturnal duties without sunlight exposure, hence showed lower prevalence of pterygium.
Components to your talk. You started with the comparison between the two grafts, conjunctival autograft and the preserved amniotic graft. For the second part, what role does it play with the first one?
Sir, actually I had collected data to present about everything, the surgical outcome of both the grafting techniques and the epidemiological data as well. So
epidemiological data itself could have been a paper, yes, that is a separate thing.
Yes, sir.
And the two grafts that you compared,
yes, sir,
from the cytological study, that was a different topic.
Yes, sir.
So why combine the two? Because ultimately you said both they are having the same result, yes, in the cytological impression study.
Yes, sir.
So the whole thing becomes confusing.
Sir, for people coming from extremely rural areas, extreme peripheries, we should go for conjunctival autografting because conjunctival autograft showed lesser rates of displacement. I followed up the patients after my study period was also over. So the graft displacement rates were much lower in CAG patients as compared to AMG. And AMG, since we are using sutures to keep the graft in place, so
irrespective.
I just like to emphasize that again. When you're presenting in a competitive session, you should stick to the title, right?
Yes.
And when you're presenting the data, the first part should be epidemiological data of both the groups, comparing the baseline characteristics, and then you go to the primary outcome measure. Primary outcome measure is always the study title suggests what you are going to do. For example, you are comparing two methods and the outcome measure was cytology, right?
Yes.
So your emphasis should have been what happened to the cytology and what was the difference between the two groups in terms of that.
Yes.
This epidemiology part you discuss later on. But you could have discussed that in the beginning itself. My study epidemiology is this, and these are the group characterization and comparison.
Yes.
Just reframe, then it will be very.
Of around 12.5% in recent study, diabetic retinopathy can lead to irreversible vision loss. Hence, annual screening is needed for early detection and timely intervention. And to ensure compliance to this annual screening, patient awareness and education is of utmost importance. The aim of this study is to assess knowledge, attitude and practices of diabetic retinopathy among diabetic patients and to explore barriers for regular eye checkups and to find any correlation between awareness of diabetic retinopathy, education, socioeconomic status and age group. This was a hospital-based cross-sectional study over a 6-month time period where all diabetic patients, regardless of their type and duration of diabetes, were included in the to knowledge about severity, preventive measures and treatment modalities for diabetic retinopathy. Data analysis was done by SPSS version 26.0 and categorical data was tested by chi-square test and correlation between continuous outcomes by Pearson correlation test. Coming to the results, the mean age of the study population was around 55 years, 69% of the population being male and 69% from the urban areas. Majority of the patients belong to upper and lower middle income classes according to modified Kupuswamy classification. Among the study population, 33% of the patients were found to have diabetic retinopathy with grading as given here and 21% had macular edema. Around 79% were aware that diabetes mellitus could affect the retina, but only 50%.
The case. Now this is a case where it's just a polar cataract. And I'm making my rexus, but inadvertently the rexus is a little small. Now I do not factor that in. I continue to go ahead and I then do my hydrodelineation dissection. I'm doing unnecessarily overzealous hydrodelineation. That whole nucleus is coming forward. There's a pupillary snap sign, and I clearly know there's a posterior capsule blow up. Now I have an entire nucleus in the back. So I was sitting temporarily. I come to the superior position, make an SICS incision, enlarge the inner lip of the bone. The rexus was small, so I make a tangential nick in the rexus and enlarge the rexus. Because now with the PC blowout and the whole nucleus, I need to get this entire nucleus out. So I need a little larger rexus. So I get the nucleus up into the anterior chamber and go in and scoop it out. Now it's not just, story doesn't end there. I have to place a suture to close the scleral incision, then go through the two side ports and do vitrectomy. I would
study setting. My recommendations are for the students: follow the 20-20-20 rule, maintain proper lighting and posture, limit continuous screen use anti-glare filters, ensure adequate hydration and sleep. For the institutions, provide vision screening programs, improve hostel lighting standards, promote eye health education, encourage outdoor activities. So medical students in hostel are at significant risk of ocular morbidity due to lifestyle and digital tool uses. Majority experience symptoms of digital eye strain,